Thank you. Well, I'll initially say thanks to the organizers of the meet who have given me this opportunity to be here, share some thoughts with you. And I also like to thank you all who have spared this Saturday evening, and I hope I'll be able to justify the time you have invested here. The cardiovascular diseases remain the scourge of the society today. If we count the myocardial infarct, cerebrovascular accidents, paralytic attacks, amputations, they are the real burden for the society today, and hypertension remains the most common disease which almost all of us will have to face and treat. When I was a student, I graduated in 1980, we were taught, most of it has changed since then, we were taught that blood pressure rises with age. We had a formula 90 plus age in terms of systolic blood pressure. But WHO did a fantastic study, and they studied what is called as a word primitive population. I must apologize, this is not a word I will like to use. I am sure those societies are reasonably advanced in their ecosystem. But when you looked at Bantus in Kalahari or far away Mayans, most of those populations don't exist anymore. Or Mayans in New Zealand or Amazonian Indians or Eskimos, they couldn't find a single person whose blood pressure was more than 120/80. They couldn't find a single individual. And if you looked at this vast survey they did all over the world, not only they found that, they also discovered that, so first thing which went out of the board was that it is not an age-related disease. Second thing they found that as people moved, now we talk of migration as political migration, that you have migrated with a green card and all that. But remember, most of the migration today is biological migration. So if I look at my own life, I moved from Allahabad to Liverpool and Liverpool to Delhi. So I have migrated twice in my life. So it's more in the migrants. As you move from a small village to town to bigger cities and big metropolis like ours, which is the second biggest in the world in terms of human population, the disease is more. So it is some complex disorder with multiple genetic factors. But again, there was another thing. Why treat the blood pressure? Because patients will always feel better when they stop medicine. It is one of those diseases where patient will love to stop medicine because the disease has no symptoms, and he will feel better after the day he stops medicine. But again, the various trials have showed that once you reduce the blood pressure, you reduce the cardiovascular event. So you have to tell the person you not only prevent the heart attack, you must tell him that you prevent the paralytic attacks and dementia. Unless you tell him this thing is not going to take the medicine, he'll be better off using a Rudraksh or magnetic ring or whatever. I was told that systolic blood pressure is the surgeon's blood pressure and diastolic blood pressure is the physician's blood pressure. That's what I was taught when I was a medical student. Remember, it's the systolic surge which damages the vascular endothelium. It's the systolic surge which damages the vascular endothelium, and that's where all the problems arise. So even the systolic blood pressure is important. So as I said, once you tell him that once we start treating you, it's going not only to prolong your life by preventing all these diseases, you also improve the quality of life. So these are the two things you have to tell the patient, otherwise he is never going to take the pills, whichever you prescribe. These are the ideal average, for less than 120/80 will be very difficult to achieve. But you should target if there is LV dysfunction, diabetes, kidney disease, or the lady with pregnancy. This is something we should target. The importance of lifestyle modification will always remain the cornerstone. So I am not excluding the importance of diet control and dynamic exercise, and especially the reduction of the salt intake. taking enough sleep. So I'm not underscoring the importance of these. Second thing I want to tell you, the most important thing is reducing the blood pressure, not the tablet which you have prescribed. So you must also think about the compliance and what he's going to tolerate. You should also look at we must also realize that we are dealing with a population which is not a captive population. He is allowed, I've worked in England for many years where the population is primarily captive population. He is your GP decides. So here the population is absolutely non-captive. There is no decent foot the bill from his own pocket. So we should not only we should look at the three major costs: drug cost, cost to the visit to the physician, and the amount of money is going to pay for the lab investigation. Some important drug interactions, like if the patient has diabetes, I think I'll part with this. So can you take this? It will not compete with. So if the patient has diabetes, ACE inhibitors and ARBs have to be important part of formulary. In anybody who has LV dysfunction, you should consider an ACE inhibitor or an ARB. And if he has an MI, consider beta blocker, ACE, ARB. Again, angina, beta blocker and calcium antagonist come into the play. If the patient has atrial tachycardia or atrial fibrillation, beta blocker and drugs like diltiazem, verapamil will come into play. Essential tremor, of course, beta blocker and cyclosporin induced will have calcium antagonist as the choice. Special drug interactions like beta blocker for hyperthyroid, beta blockers for somebody with migraine. Osteoporosis, thiazide has advantage because it helps the bone. If the patient has prostatism, then alpha blockers have advantage. Some special contraindications as well, we should know that the beta blockers are not good for asthma, depression. Clonidine and reserpine are also not good in somebody who has depression. I'll skip some of these two in the interest of time. The way I practice, most of the patients of hypertension we get are sent to us because he may have renal artery stenosis, because somebody is not able to manage the blood pressure with multiple drugs. I follow some very simple rule, and I hope you will also find it useful. I just follow two words, NANA and ABCD. Just two words, NANA and ABCD. And let me tell you the rationale behind it. As I told you initially, we don't yet understand the nature of this beast. It's a complex thing. But the two things are important. Blood pressure is a simple product of cardiac output and peripheral vascular resistance. So increased renin activity is more common in young, and high cardiac output is more common in elderly. I sort of take cutoff age if the patient is less than 55 years. So this is the logic of NANA. That younger NANA, one is non-adrenaline, high reserpine, and one is NA, fluid overload or sodium, which represents the fluid overload. That was the first basis, NANA. And second is ABCD. If you look at antihypertensive prescription, nearly 90% of drug will be just ABCD. A stands for ACE inhibitors or ARB, B for beta blockers, C is a calcium antagonist, and D is a diuretic. So if the patient is young and I take the cutoff age of 55, if the patient is younger than 55, I start with A or B. If more than that, I start with C or D. This is how I practice. So, and if you are not able to control the blood pressure in the first instance, what you should do the next. So here, as I said, in the younger function, I started with A and B, and older with C and D. If one drug is not working, so from A and B, I will switch to this way. From A and B, I'll go to C and D, and if it was C and D, I'll go to A and B. If you look at the pharma industry, they have gone for it. Amlodipine, they will sell with beta blocker or an ARB. Again, they will send ACE inhibitor with a diuretic. So these combinations, that's how they have acquired it, and that's how we should also acquire it. So from first class, switch to another class. When 2 is not working, then only come back to the first class, to the first category. I'll be very happy to take question in between if you are young, want me to take a question. Second thing I will say, once you go to multi-drug regime, diuretic has to be an important part. Unless you reduce the circulating volume, you are not going to achieve much. Especially in an elderly female, unless you reduce the circulating volume, you are not going to achieve much. So you have made this combination. If you are using multiple combination, make sure you have a diuretic in it. If you still the blood pressure is not being totally controlled, consider using an alpha blocker. Then comes you have tried this, it's not working, must consider alcohol. Alcohol is one of those agents which increases the blood pressure. So if you somehow could persuade the patient to reduce the amount of alcohol he takes, to reduce his weight, his medicine requirement will come down. Patients who have long-standing hypertension develop secondary hyperaldosteronism. These are the patient and the CKD patient where you will find it most difficult to control. Hyperaldosteronism is highly underdiagnosed. There is no good lab test which will help you to diagnose this problem. Potassium in most of these patients will be normal. So best thing will be just to give him a trial of spironolactone. If spironolactone is reducing his blood pressure, then you should add a spironolactone. So you have gone through this combination, you have given it. I must say, if it's a lady who's 45 and above, think of spironolactone also, because here is one place where you'll get a lot of benefit. If it doesn't help, then you should think in terms of clonidine. If he gets sleepy with clonidine, you should think of moxonidine, and if it still doesn't help, then think of alpha-methyl-dopa. If he still is hypertensive, then comes the minoxidil, and it will almost always reduce the blood pressure. So this is one slide where I have given all. This is just what I follow, and it will almost always work in all patients. The patients which get dumped to us as a renal artery stenosis, most of them have normal renal arteries. Most of them have renal. This is the regime we follow too. Second thing you must tell them that blood pressure you should take on average. One reading goes high, doesn't mean you increase the tablet. One reading goes low, it doesn't mean you reduce the tablet. And second thing, you must give them something which should be something in the regime which they should be able to add for the winters, because most of the patients will have the higher requirement of medicines in winters. It is I think it's very strange if you have a interventional cardiologist visiting you and not showing a CD. So I'll just like to show you a CD and then come to the combination. This is a lady who has, as you can see, the pointer please, pointer. This lady has calcified. She has calcified stenosis all the way in LAD, and it is total stenosis at this point. And she has a very high creatinine as well, which was 4.7, and turned down by the surgeons. So ordinary rotawire is a highly calcified, so we have to think of rotablator. The rotawire will not cross, so we cross with a standard wire, and this is what we call microcatheter to confirm we are in the true lumen. So we have confirmed that we are in true lumen. Then this is a rota burr which is used to make a channel, because a highly calcified artery, nothing else will work. So we patch it up with balloon, and we have implanted one and then second stent, and this is the second stent. It has been implanted. And so in the interest of time, I'm just showing you the final pictures. So even though it was highly calcified artery with a high creatinine which surgeons have turned down, she's doing well. Now, another thing which you will realize in cardiovascular medicine, that patients have high blood pressure, they have diabetes, and they have either ischemic heart disease or the cerebrovascular disease, somebody who has had a stroke or angina or MI. Now, these are the patients which form a large bulk of our patients and where things are difficult to control and where the combination drugs come into the practice. I use Polycap. I must say I am not a proponent of fixed drug combination. But there are a lot of drug combinations which have scientific rationale. Scientific rationale to the extent that they have given a generic name, co-amoxiclav, which is marketed as augmentin. Amoxicillin have been combined with clavulanic acid. Co-amylofruase is become sort of generic. Furosemide, you combine with amyloride because they improve the outcomes in the patient. And that's where the drug combinations start coming into the play. But there is a very big problem in the cardiovascular medicine because patient has to take the pill for many, many years to come. That's one. And the most important thing about the effect of the drug is that it will only work if the patient has taken the drug. You may have prescribed it, he may have bought it, but if he has not swallowed the tablet, it's not going to work. So this is the most important part. The drug will only work if it is taken by the patient. And long-term compliance is a very big issue because patients don't like popping so many pills for a long time. I have told you initially that you must tell the patient that he will feel better if he stops the medicine. So you have to tell him that even though you will feel better, but you will be worse off in the time. So the single biggest problem is the patients tend to count the number of pills they have to take. That is they just tend to count that 6 गोली सुबह खाते 4 गोली रात खाते 10 गोली रोज खानी पड़ी. So pill count remains the biggest problem. So once you use the drug, the pill count is drastically reduced. This is the single biggest advantage. And second is the cost advantage. So this is the biggest rationale of the drug. And this combination is, I talked about antihypertensive. It has atenolol as A, ramipril as A, then it has hydrochlorothiazide, and I told you how they cross and the combination. So it's a very rational combination of the three drugs. Atenolol is still one of the best beta blocker in antihypertensives. Ramipril is a time-honored ACE inhibitor, and thiazide remained the cornerstone in the antihypertensive therapy. Once it comes to antiplatelet therapy, aspirin remains the gold standard, is still the best, and if you have to use one antiplatelet, aspirin is still the best. Then you have to think of the lipid. If you look at the literature, the amount of literature available with simvastatin is unparalleled. If you look at the number of years the patient have consumed statin, if you look at the amount of patients who have consumed simvastatin, it will outnumber atorvastatin or any other statin by many folds. So it's still a most important statin today. And simvastatin has another advantage, it has a short half-life. So it's a very rational combination. So when you give the patients who have a stroke, MI or hypertension, if also have diabetes, the pill count is reduced, compliance is improved. That's the very big advantage. Such combinations are not only rational, they are pharmacokinetically stable. You can have two problems when you are using this combination. One problem is patient's blood pressure is suboptimally controlled. You can add some other agent like amlodipine or alpha blocker, whichever be your choice. Other could be the LDL is not coming down to a desired level as you will like it to be. You can add a fibrate, an extra tablet of simvastatin or ezetimibe. Oh, some slides are missing here. Some slides are missing, but anyway, in the interest of time, that's lucky. So, I'm ready for any questions that you may have or anything in cardiology, not only this. Anything in cardiology.
Hypertensive urgency and hypertensive emergency. These two things are sometimes mistaken by GPs, and we are not able to tackle at our clinics. So what we should do in these two conditions?
So you have mentioned two things, hypertensive emergency and hypertensive urgency. First thing you should know that blood pressure level is not an emergency. That's first thing you have to tell the patient. Emergency in medicine is if it's life threatening, limb threatening or sight threatening. These are the three emergencies. So hypertension becomes an emergency if there's retinal hemorrhage, cerebral hemorrhage, acute MI, hypertension leading to LVF, preeclampsia. So these are the situations where it is hypertensive, patient requires admission. Urgency has a very wide spectrum in this. Most of it is the patient's response, the way patient, if the eye is there, it's not. Urgency has a lot of gray areas. But emergency has well defined. These are the situations it becomes life-threatening. Your second part was how to handle it. Admit the patient in emergency. That's number one. Number two, think of short-acting drugs. In any emergency, the golden rule in medicine should be think of a drug which is short-acting and acts rapidly. Most popular will remain nitroglycerin because it will reduce the blood pressure. It has a short half-life. You can get away quickly. Cerebral hemorrhage, etc. Here you can think of nimodipine. Preeclampsia, labetalol is very popular. But most important thing, you should be able to control it, whichever agent you are happy with, as long as you are able to titrate the dose quickly in these situations.